It's my great honor to be here in the second Symposium, Serotonin and Anxiety and Depression. I'd like to thank Professor Claudia Padova for inviting me and Professor Fred Greff for the opportunity to take part in this symposium. I remember the first symposium that I was just arriving from UK and several forums of neurobiology of stress, and take part in this meeting again is my great honor. My talk here will be about stress and HPA axis and depression. Stress and hypothalamus pituitary adrenal axis is quite linked with stressful situations and is one of the main factors that could be related to depressive episodes, even unipolar depressive episodes or bipolar depressive episodes. And so it's quite important for us to have these axes in mind, you know, because even different stressful situations will bind and will link it and will start it as a trigger of the hypothalamus pituitary adrenal axis releasing cortisol. And so this circulating cortisol is not only linked and related to HPA axis, but also to other areas like amygdala, mind-brain, hippocampus. And the main point is this cascade is related to different receptors, GR receptors, glucocorticoid receptors, and mineralocorticoid receptors, mainly in the hippocampus. As one of the main researchers in the area, Professor Ron DeClos, that went to our campus here in the University of São Paulo a year ago, and with Mary Yogos brought a very nice light in this research. I really liked this statement here when he said that if cortisol receptors are imbalanced and impaired, the individual loses the ability to stress adaptation. And this is quite important because the receptors are a little bit different from the serotonin receptor, the catecholamine receptor, and other neurotransmitter receptors that are localized in the membrane. And so, as you can see here, the glucocorticoid and the steroid receptors are in the cytoplasm, and they are really closer to the nucleus. And so the impact in DNA and even in different kinds of physiologic and pathophysiological effects are really important when the stressful hormones like cortisol bind and started this cascade that will have an impact in the nucleus and in the genetic area. And so you have this animation here. I hope you enjoy. You can see here the different kinds of glucocorticoids that enter in the cytoplasm, bind to GR, and this heat shock protein 56, 90, and then it starts a new compound that is activated with the glucocorticoid and the glucocorticoid receptors. And then in the cytoplasm, they suffer a translocation to the nucleus, and then they have negatively or positively altered genetic transcription. And so this is something that is quite interesting because in the theory about stressor intensity and how the suppressive glucocorticoid effects mediate glucocorticoid receptors, the two receptors have different behavior. For instance, the mineralocorticoid receptor have a higher sensitivity to lower levels of corticosterone in animals or cortisol in humans. And so, as you can see here in the very beginning, with lower stressful situation, lower corticoid release in the plasma, you have a very high activation in the mineralocorticoid receptors. Even if it increase the stressor intensity, we can see that not only the MR but mainly the GR receptors start to have an activation. And so this is the balance that Ron Declos proposed between the two receptors, the GR and MR. Like in Ribeirão Preto, the two football teams, Botafoguinho and Comercial. And so you have the balance. In the south, you have Inter and Grêmio. I am supporting Inter. Chico supported Grêmio. And so you have a balance between the two receptors as well. And mainly we can see here very high intensity stressful situations with very high corticoid release. We find this in patients, mainly depressive patients with several depressive episodes or bipolar episodes. You see that will have a very high impact, mainly in the glucocorticoid on the GR receptors. And so this is also can be translated to cognition. I'm quite interested in the cognitive performance, and so if you use this balance between the two receptors and the circulating levels of glucocorticoids, you can see that in optimal levels with a very high cognitive performance, we can have a complete occupation of the mineralocorticoid receptors and just partial occupation of GR receptors. But if you have a very low stressful situations, you are not really related to the task and you are not trying to do your best performance, you have a low occupation of the MR and even no occupation of the GR. But on the other hand, if you have a very high stressful situations, very high levels of glucocorticoids, you are not eating, you're not sleeping, you're just studying hard, you're trying to do your best, but you're not organized, and so you have stressful situations for intellectual or even a physical activity, you have a very high occupation of both receptors, but you don't increase your cognitive performance. And so this could be related to serotonin, that is one of the main topics of our symposiums here. We can see in a relative serotonin response, let's say 100% of serotonin response, very healthy. You don't have an activation of the GR and MR receptors. But when a patient or even a volunteer, a healthy volunteer, suffer an acute stress, he can activate the MR receptors in the very beginning, and then to recover to the same level of serotonin response, you have acute activation of both receptors here. But with patients with chronic stress, several episodes, it happens in a different way. They already start in a very low serotonin activity response, and then when you give an antidepressant, for instance, you can improve a little bit, but not too much, even with the help of the GR and MR receptors. And so that could be the difference between health that could handle with acute stress and patients that suffer chronic stressful situations and developing some kind of disease like affective disorders, depression, and others. And so, as you can see here, the glucocorticoid concentration is quite linked with the different kinds of mental illness or even other chronic illness. For instance, if you have hyperactivity of the HPA axis, you can have a typical depression, for instance, a craving for carbohydrates, hypersomnia, and a different pattern comparing with melancholic depression that have a hyperactivity of HPA axis and anorexia and insomnia and different patterns of levels of cortisol. Melancholic, you have a very high levels of cortisol, hyperactivity of the HPA axis, and a typical depression with a very low levels of cortisol, like you can find in chronic fatigue syndrome. PTSD is one of the main disorders with more evidence about this. fibromyalgia, bipolar depression as well. You can see hyperactivity. And this is mainly related to the activity and the decrease of the mineralocorticoid receptors. On the other hand, here maybe you have a hyperactivity of the GR receptors. Of course, as I said, the optimal levels in the middle with the balance between the two receptors that probably will be related with resilience and a healthy pattern. As I said, I have been studying and did some collaborations in a master in affective neuroscience in the University of Maastricht, where I have been in touch with the Professor Van Praag group that have developed several studies in the 70s, in the 80s, and he published some years ago how can stress cause depression. And most of his studies are linked to serotonin. And I would like to indicate this very nice review that can explain a little bit how can serotonin in stressful situations can developing chronic depression and other kinds of affective illness. Professor Bob Post, that is a very kind man and one of the pioneers in affective illness, developed a very interesting model about kindling and the sensitization in affective illness when the very first stressful episode can precipitate the chronicity of affective illness mood disorders. In the second phase of the illness, Bob Post proposed that the episode sensitization is a consequence of the illness, affective illness. You don't need it, as you can see here, that the target is decreasing the size, and you don't need a stressful precipitant to start a new episode. And so this is the kindling model that you can understand that is quite important when you could correlate this with early life stressful situations and the chronicity of depression in the different patterns. As you can see here, this is the measure of cortisol along 24 hours. You have the normal in the middle, normal healthy volunteers is very interesting data. And so you can see here the melancholic depressive patients with very high levels, almost the double of normal people. And so our proposal is measuring these atypical and bipolar depressive patients with lower levels than normal patients, and I show you some data about that. And so we published some years ago that early life stress in HPA axis could trigger recurrent adulthood depression and recurrent resistant adulthood depression. And so I already showed you the HPA axis in normal people, and so you have the release of cortisol after some release of other hypothalamic and pituitary hormones, and so this cortisol released from adrenal cortex will bind to pituitary and hypothalamus receptors. Melancholic is the opposite, as I said, and so you have a higher levels of cortisol being released from adrenal cortex, as you can see here. The size of the target is bigger, the arrow is bigger, and so you cannot see here the negative feedback working well, and probably this is linked with the receptor that I already mentioned. In the PTSD, you have exactly the opposite here. You have the decrease of the CRF, and you have a release of lower levels in hypoactivity in patients with post-traumatic stress disorder, atypical depression, and bipolar depression. And you have probably overactivity of the receptors perceiving these low levels of cortisol. We published some data regarding not only cortisol but other adrenal hormones like DHA in treatment-resistant depression, showing that the ratio between cortisol and DHA is higher in patients compared with controls. We found that this is even higher in patients with treatment-resistant depression patients, the ones that could not respond to more than 2 antidepressant treatment. And probably this is one of the indications of the greater biological dysfunction in this HPA axis. But as I said, early life stress is something that is really impacting the chronicity of these disorders, and probably will have a high impact in the receptors, MR and GR receptors. Some kinds of early life stress could be child abuse. You can see here some kind of emotional abuse. You see the dad is shouting. It's not physical abuse. It's just words depressing the child. You can have physical abuse that is quite impacting. Some strong pictures here, mainly related to alcohol abuse, psychiatric disorders. Sexual abuse is one of the biggest problems as well. And emotional neglect, as you can see here, the mom is watching the computer, talking in the mobile and drinking a tea, maybe a coffee, and the child is here just bargaining for some attention. And so physical neglect is something that could happen in all over the world, but mainly in developing countries. And so this kind of early life diversity will decrease the levels of GR and MR in the hippocampus comparing with normal developing. And so you can see that stress can activate the HPA axis, as you have seen. And the binding of this cortisol to GR in the hippocampus is very poor comparing with normal developing. And so what happens, you have a lack of inhibition of the HPA axis, and you have probably overactivity of the HPA axis, increasing the stressful perception across the environmental area that the patient is related. And so this is a very important point, maybe the keystone of all adult psychiatry disorders. And some authors say that you have patients with mental disorders with early life stress and patients with mental disorders without early life stress. And probably around 70% of all the mental disorders are linked to early life stressful situations. And so this is a paper that we publish now with more than 200 citations from one of my students, Clara Carr, in a collaboration with some Cariocas researchers that we try to correlate this. This is another paper that is quite interesting to show the increase of suicidality in the clinical course of these patients if they suffer childhood adversity, increasing a lot the clinical course and predicting lifetime suicide attempts and physical abuse that could predict as well some kind of psychosis. And so for review, I think this is one of the best papers by Sonia Lupin and Bruce McQueen, Gunnar and Christine Hein, that can show the stress across lifespan. And so you can see that even in prenatal stressful situations, you can have a program effects in the HPA axis. If a child suffers a postnatal stressful situation, like maternal separation, it can increase glucocorticoid release. If the child suffers severe trauma, like child abuse, it could have the opposite in long terms, you know. And so this is something that is sometimes paradoxical, and so that's the situation that the diagnostic is quite important, even early diagnostic, to understand a little bit how is the impact of these glucocorticoids in areas like amygdala, hippocampus, frontal cortex, and how it happens to developing depression that, as I said, melancholic increase, glucocorticoids, or the decrease of PTSD, and even in adulthood, aging elderly people that could have a cognitive decline, and probably you have a higher impact in this area after the 50s or 60 years old. And so I like to show, I know that some of you are preclinical researchers, as you can see here, a mom with the puppies and try to grooming and licking their puppies, as you can see here. She's a good mother. Yes, as you can see here, is taking care of all the children. And so what's happened here? You have low grooming or high grooming. And so you can see this high grooming will have a very important impact in the GR gene and GR receptors. And so grooming could increase the GR sensitivity in these GR receptors. And so what's happened with the stress response? If you have a high grooming, you can really decrease the stress response. The opposite is true, and so you can increase the stress response if you have a low grooming, and there's a bad mother is really impacting in the developing of their children. And so this is programmation, but you can have demethylation is really caused by maternal care, but it's really can be changed if you have a good adoptive mother. This is a low grooming mother, and here a high grooming mother. But what happens is you can really change the methylation with a adoptive high grooming mother, and you really change as well if you have a biological mother with high grooming, and then you change it to a low grooming mother. So this adoption cross-fostering procedure show that demethylation is linked with maternal care. Doesn't matter if it is genetic, biological mother or adoptive mother, it will change the methylation. And so this is quite interesting for our society and human procedures that you already have been demonstrated in some cross studies all over the world. And so the main point that you can say that is emotional abuse is one of the neglect kinds of abuse. And so one of my PhD students published this paper some years ago showing that emotional abuse is a differential factor for the developing of depressive patients. And so as you can see here, patients with early life stress and without early life stress have a different in personality disorders, high levels of personality disorders. This study was done in the day hospital, Hospital Dia of our faculty in our school here, and even suicide attempts in the past. You can see here you have very higher levels of suicide attempts comparing with patients without early life stress. And so it will change even if you just included emotional abuse. Here you have all kinds of early life stress, emotional abuse, sexual abuse, physical abuse, neglect. But here you just compare patients with emotional abuse, and so you can have a significant difference between all psychiatric disorders and mainly with depressive disorders. You can see a change in patients with early life stress, almost 70% of our sample, and without early life stress, almost a third of the patients with depressive disorder. And so this is a quite important factor to developing depressive in adults. The other situations, we are just submitting this paper using a multi-logistic regressions to analyze the difference between depression and childhood emotional abuse. And so you can see the gender, the female are really related to these, as you can see, almost 4 times. Family history of mental disorders, almost 4 times. Suicide attempts as well, more than 3 times. And hopelessness, you can see that will increase in this model of depressive disorder and emotional abuse. And so emotional abuse is like a pain in the brain, like a physical pain in the brain, a hammer and a nail. And so you found your finger instead of the nail with a hammer, and so you feel a lot of pain and this is activate some areas like PAG, accumbens, thalamus, and insula, and others. And so this physical pain is almost the same pain in the same area that have been activated with social exclusion, grief, being treated unfairly. And so emotional abuse activates a pain network. And the opposite is true. Physical pleasures like sex, drugs, is almost the same areas that have been activated. If you have heard about your good reputation, if you said to me by mail, oh, I really enjoy your talk, even it was by a video, it will be activated probably my reward network and being treated fairly in our university, increase the cooperation with the King's College and other UK universities, giving to charity. This is something quite interesting to see that you increase the reward network, and so it's completely the opposite, like you can see in emotional abuse, in pain. We published some years ago interesting data analyzing the cortisol levels in bipolar patients in their first episode. They are bipolar with manic episode, and they are drug-naive patients, never used any kind of drug. And so you can see a difference between euphoric and irritable mood. As you can see here, the control levels of cortisol are really higher than the manic patients. And when you compare these cortisol levels in elevated mood, that you can see here using Young Mayo scale, the highest scores in the Young Mayo scale have the lower levels of cortisol, and the higher levels of cortisol in the same scale you have the higher levels of irritability. And so, as I mentioned, in atypical and no atypical, or atypical and melancholic depression, here you have different patterns that biomarkers can help us to distinguish between the different subtypes of bipolar depressive disorders. And so, to go further in this, to understand a little bit better about these HPA axes, you can see that some drugs are really more selective to different kinds of receptors. So cortisol is almost in the middle. Our endogenous glucocorticoids will bind to GR and MR in almost the same pattern. But dexamethasone, that was on the first challenges to assess the HPA axis, you can see is much more GR agonist than MR. And so we're developing a prednisolone suppression test that is not perfect, but is much closer to cortisol. And now we are doing some studies with fludrocortisone that will show some results that is really MR agonist in this selectivity between the two receptors. We published in the Neuropsychopharmacology some years ago an in vitro study comparing GR function in healthy subjects and patients with depression. And we can see that clomipramine, as you know, is one of the most powerful tricycle antidepressant, could change the GR function in healthy controls, even with dexamethasone, with prednisolone, corticosterone as well. But as you can see, in patients with depression, this is very powerful antidepressant could not change the GR function. And so that's probably one of the reasons that you don't have at the moment antidepressant that could help to treat treatment-resistant depressive patients that are almost 50% of all depressive patients. And so, because you could not change the GR function, that is really a keystone in the cascade of neurotransmission and this physiopathology. We have demonstrated that, as I said before, that dexamethasone is quite different from prednisolone. Prednisolone is really more close to cortisol, not only pharmacodynamic but pharmacokinetic, almost the same half-life, and binds to almost the same proteins. And when you try to understand a little bit about this MR functioning in treatment-resistant depression, we can see that in healthy controls, the spirulactone, that is MR antagonist, will increase here the cortisol. When you use combined prednisolone and spironolactone, we cannot see. You can see a suppressive effects here, comparing to just prednisolone, because you are using antagonist to a mixed agonist of MR-AGR, and so you decrease the suppressive effects. But when you try to see these in patients, you can see the levels are really higher, 20 to 10 here, and so it's not the same scale, but treatment-resistant depression is quite associated with hypercortisolism, and there are MR function here. You cannot see the difference between spironolactone that is much higher than placebo here. Now you can see there's an overlapping between placebo and spironolactone, and so the MR, you cannot see a difference between as well the combined prednisolone and spironolactone. So definitely there is MR function in these kinds of patients with resistant depressive treatment. One of my PhD students, Dr. Christine Baez, wrote with others this very nice systematic review showing that most of the HPA axis activity, GR or MR function in patients with depression and with early life stress are really not concluding anything, because you have different results even using the same challenge. Index CRH is one of the most used challenges to assess HPA axis, and you can see here cortisol and ACTH decrease in women with early life stress, but increase in men with early life stress. And so probably the gonadal hormones have a very high impact here. We used the prednisolone suppression test and dexamethasone. We didn't find results here, but others found some contradictory results using the same challenge. And so we published last year this study of early life stress in depressive patients, the whole of both GR and MR in a HPA axis, and one of the tables you just focus on MR agonist, fludrocortisone, and spironolactone. And here again you have contradictory effects, results. As you can see here, you have some of the studies with MR agonist, fludrocortisone, increasing the MR activity, and others with spironolactone, MR antagonist, increasing as well. But here you can see that the sample, and that's the main point I like to mention here. In clinical research, you should try to put patients with the same diagnostic in the same sample. And so here we are comparing patients with depressive episodes with very mild depressive episodes, or comparing psychotic depression with decreasing MR activity with treatment-resistant depression. And so using different drugs that probably you have different patterns, you have different results or the same results. So the diagnostic is quite important. The challenges is quite important to try to understand a little bit better what really happened in this kind of situation in patients that suffer early life stress and have a resistant depression episode. And so in this paper that we published some years ago, we studied early life stress in depressive patients in response to GR agonist and MR agonist. You use patients with and without early life stress. And our hypothesis is that persistent dysfunction of HPA axis will lead to MR dysfunction in patients in adulthood with early life stress. And we collected after these challenges with MR agonist and GR agonist, salivary cortisol and CAR, cortisol waking response, and we collected all other hormones as well, with a very interesting collaboration with the laboratory of endocrinology, professor and our dean, Margaret de Castro, is the director of this lab. And the finding is quite interesting. It's a quite small sample, but it was the first time that we demonstrated that fludrocortisone have lower levels in cortisol waking response after fludrocortisone in this kind of depressive patients, comparing with healthy controls. We could not see this difference after dexamethasone, that is just a GR agonist, as I mentioned, but the MR is quite interesting to demonstrate this. And so we are working with this area here, cognitive function, lower levels, and lower levels of cortisol, with a very low ratio between MR and GR. And that we found is in early life stress, both receptors, you can see that there is a difference between MR and GR agonists and placebo, but you cannot see this in patients without early life stress. There is no suppression in patients without early life stress after MR agonist. So probably the MR agonist will have an important role to discover what really happened in these patients that suffer early life stressful situations. And we found that higher levels in trauma questionnaires, like childhood trauma questionnaires, are correlated to higher levels of plasma cortisol in this sample. And in the same sample, we found that patients with depressive and with early life stress, a positive correlation between MR agonist here, as you can see, but you cannot see the same correlation between placebo, cortisol waking response after placebo, and cortisol waking response after dexamethasone, the GR agonist. Just after fludrocortisone, you can see here the positive correlation. Demonstrating that what Professor Young, that I'm working with him now, said this is a prophetic paper, future therapeutic targets in mood disorders are linked to GR receptors. But I would like to add that MR is quite important. And this is not only future targets, but in the present you already can do this. Improving stressful situations in bipolar, you can decrease really the sensitivity to stressful environment, or using MR antagonists like spironolactone. I have been developing in studies in trials in this area, and you have demonstrated that MR antagonists could decrease in this sample with bipolar depression and atypical depression the stressful reactivity and improving the symptoms, depressive symptoms as well. The last point that I'd like to mention is regarding child abuse and suicide attempts. And so, resistant depression and suicide are quite linked, and, as you can see in this paper published some years ago in the British Journal of Psychiatry. Suicide ideation and suicide attempts increase after physical abuse and sexual abuse, comparing with negative childhood abuse. We found as well in our data here in Ribeirão Preto a nice correlation between the scores in back suicide inventory and the scores in childhood trauma questionnaire, showing that positive correlation between these two important symptoms regarding abuse and neglect. And so when you can see back suicide inventory and measure this in the admission of these patients in the day hospital, they have almost the same scores here in the back suicide inventory. 60 days after treatment, as you can see here, patients with all life stress still have moderate to severe suicide ideation, and the patients without early life stress, the day hospital is working and they decrease the suicide symptoms almost to zero, you can see here. But I have to say that this is just 30% of our patients is here. 70% of our patients is here. So this is the reason that you need to do some research to improve it. And so the same pattern you can see not only in this the scale scores, but all in the salivary cortisol levels. You can see admission 60 days after early life stress, patients, they don't change the levels of salivary cortisol when you have a different pattern comparing with patients without early life stress that decrease the levels of activity of the HPA axis. And so my last slide, I believe so, is our data here. You can see the levels of the 5 points of the childhood trauma questionnaire: emotional abuse, physical abuse, sexual abuse, emotional neglect, and physical neglect. You have a nice collaboration with Stuart Watson and the group of Newcastle University Neuroscience Institute in Newcastle. As you can see here, they measure bipolar 1 emotional abuse, no more than 10. Our levels here is more than 16, 17. Physical abuse, you are going to up to 12. They don't go up more than 7. And so in most of the subclusters of the childhood trauma questionnaire, the Brazilian family, the Brazilian child, suffer much more abuse and neglect comparing with English childhood or English patients with bipolar disorders. And so this is something quite important for us to understand, and even for them to compare with more severe sample, the Brazilian sample. But of course, biomarkers is biomarkers. It should be correlated with phenotype or treatment response, therapeutic response. And so biomarkers should be linked to specific phenotype. You could not put bipolar 1 and bipolar 2, irritability levels, high and lower levels of euphoric episode, or even atypical depression and no atypical melancholic depression in the same sample, because in this way the diagnostic, the phenotype will be different, and then the biomarker will be different. And so the composed outcome is meaningful subgroups is our main conclusion and our main messages to you in this talk. Okay, I'd like to thank the Royal Society and CNPq, FAPESP, of course our university here with FAEPA, and now the possibility to join our group Stress, Trauma and Doença Afetiva Estrada to the Academy of Medical Science and the Institute of Psychiatry. And here you have my email address. I'll be happy to go deeply in this short talk and to keep in touch with you. Thank you for your kind attention, and keep in touch.